Good afternoon, ladies and gentlemen. It's a great pleasure on behalf of the conference to welcome you in this special session. As the saying goes, those who forget the past are bound to repeat it. So it's good to look back, but also look into the future in the context of decolonizing global health. We have a very good lineup, I think, and we have a very special guest. And I hope that together with this lineup and your attendance and your involvement, we have an important and also productive session. And in order to get that session started, I now give the word to my co-chair, Godelieve van Heteren.
Thanks a lot. I don't like these kinds of setups, although the text is very good. Shaping the future for an equitable and sustainable planetary health. We're all here, and this is day 4, final day. I see a lot of people that have been energized over the last few days in collective conversations, beautifully. And we all know that throughout this conference, there are some crucial conversations running. Now, the Dutch part of the audience might be super depressed after yesterday. No reason for it. This is just a test case, guys. I say this to the Dutch. So this topic that we're going to discuss now, Decolonizing Global Health, is as topical as it can be. So we'll discuss on how this session is going to play out. But already I want to give a big applause to our 2 special guests, because they're absolutely fantastic. Dr. Patrick van Galen and Dr. Ndungo from ITM, but basically he's married to a Dutch. There's a whole story linked to him. But I want to give him a big applause for being here. Now, I was personally the other day in a fantastic session, which was about discourses of coloniality. I see some people in the front row, they were all mobilized to come here as well. Thank you guys for being here on day 4. And in that session, we were talking a lot about how can we really move beyond the talk. The talk has to be analyzed. It's still very important because we use so much crazy language still. But it's very important that we move beyond. Now, I thought, what can we do to create a sense of the plurality of voice? And I have to say, I'm super happy that with one phone call, I managed to get Leonie Jansen, who's an old friend, who has worked with the African Mamas. Some people might have seen her in concert. I phoned her, I explained the situation. I said, we're in this big hall. This is normally music time. We need some music. So she said, okay, I'll come. So here's Leonie Jansen, and I'm super happy you're here. Leonie, the floor is yours.
May the rain always fall soft upon your field, and the sun pour down like honey where you stand. May the wind be at your back and the road rise to meet you, and your soul rest at last in the hollow of God's hand. I started this little musical session with a song from Ireland. It's called The Blessing. And at the end of the session, I will sing the total song with my guitar. But first, I'm a singer and director from Holland. I love to work all over the world and make collaborations. And one of the most beautiful things of collaborations is that I cannot know all the languages, but I do know music, and in music we can always find each other. But it's always also in voices. We can't raise our voice and talk and be one, but we can raise our voice and sing and be one. So I'm going to sing with you. Are you up for some singing? And it's a little bit difficult because this hall is very... The people are sitting on different places, but yeah, let's try it. I'm going to sing something, and you're just going to copy me. I'm going to divide this room in 3 parts. Here is the first part. So the last 3 rows are from this section. And this is the whole section, and that's the third part. So everybody up there, it's the third part. Everybody up here until the next 2 rows is the second part, and people are here the first part. Let's start with the first part. Hey, ho. Just copy me. And hey, ho. You are also a part of that, because you're sitting very up high. So let's go again. Ho. That was much better. The second one. Okay, this part. Ho. That's the meaning. Ho. That can be louder. That can be louder. So, I start with this one. Which part do you want to sing along? The first part. Any. I don't have to write down the lyrics. It's just ho. Let's start with the first one again. Ho. 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 Okay, now stand up, everybody. There's only one chance to do this. And I will sing for you after this session. I will sing alone. Now we are singing all together. One voice. Okay, what I'm doing now is I'm going to sing the first voice for you and then the second one, and you keep singing along. And then I'm going to sing it with you, and then I'm going to sing it with you. And what happens that we have 3 voices. I think there are 400 people now here, all different voices. And we have 3 types of musical lights and 1 rhythm. So I'm going to prove that within 5 minutes we will sing a 3-harmony part all together. By the way, it's an African tune. Hey-ya-ya, hey-ya-hey, hey-ya-ya, hey-ya-ho. 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 We're gonna do it one more time, because the ending, when I do this mark, then it's the last one. Then I do this, then you keep holding it on until I do back. Okay, and I want everybody to stand not like this, not like in the football position, hands loose, and you are allowed to move. So use your voice, raise your voice, and let's sing this one more time together. Are you ready? Hey ya ya, hey ya hey, hey ya ya, hey ya ho. Hey ya ya, hey ya hey, hey ya ya, hey ya ho. Hey ya ya, hey ya hey, hey ya ya, hey ya ho. Hey ya ya, hey ya hey, hey ya ya, hey ya ho. Hey ya ya, hey ya hey, hey ya ya, hey ya ho. Hey ya ya, hey ya hey, hey ya ya, hey ya ho. Listen to those beautiful voices, the beautiful sound you're making, the sound where we can change the world. And the last one, let's go. One more time. That's man, how beautiful that was. Okay, as a reward for your singing, I will sing this song for you. You also heard it's an Irish blessing. I wish you a lot of wisdom and a lot of strength on your path to a healthy world. May the rain always fall soft upon your field, and the sun pour down like honey where you stand. May the wind be at your back and the road rise to meet you, and your soul rest at last in the hollow of God's hand. Life isn't easy. No one ever said it was. But if you are lucky, you will love and be loved. And may the rain always fall soft upon your field, and the sun pour down like honey where you stand. May the wind be at your back and the road rise to meet you, and your soul rest at last in the hollow of God's hand. Trouble and sorrow carve the lines in your face, but don't fear tomorrow, oh no. You got to meet it with grace. And may the rain always fall soft upon your field, and the sun pour down like honey where you stand. May the wind be at your back and the road rise to meet you, and your soul rest at last in the hollow of God's hand. May your friends be as many as the promises that you keep. May your laughter in heaven leave the devil to weep. And may the rain always fall soft upon your field, and the sun pour down like honey where you stand. May the wind be at your back, and the road rise to meet you, and your soul rest at last in the hollow of God's hand. 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 Thank you.
I mean, one more applause for her, because she made my day. Okay, that being said, we're super happy that you did this, because we all feel, after these 4 days of conversation, we have to connect. We have to really connect, and this is a way of connecting. From here, you can have different conversations, so we're going to have some very beautiful contributions now. And I have to introduce them quickly, and I don't know, I wish I could do a moment of silence before going to the slides, because it's such a downer after what we just heard. But all of you have been here, or most of you have been here for the last few days, and we had these beautiful conversations about the depth, the foundational shifts and changes that are happening under our eyes, with in part our active involvement, and with a lot of uncertainty. And so the conversation that we'll continue here, which is about decolonizing global health, is one of these deep conversations. And nobody is the expert. Everybody is in it, because we're all actors in the world as we experience it. But I borrowed, with a lot of thanks to the lady who organized this session, Mrs. Hoffeller, who gave a session on discourses of coloniality. And in the session, who was in the room here that was actually also in that session? I want to see some hands. As you remember, it was very animated, because it was how half-consciously, unconsciously, all these structures, so officially colonial systems, so-called, no longer exist, but colonial systems do exist as we speak. And so she gave a whole sort of nice introduction and workshop where she talked about coloniality of power, knowledge, and of being. And to deconstruct that on the one hand and say we need to really get rid of some of this, or maybe most of it, and move to a beyond, it's work in progress. It's not finished, it's actually still there, and we're all part of that. So I'm so happy that all of you came, because it's a sign that it was part of the conversation. Yesterday, when we had the discussions about race and racism in global health, same part of the same fundamental conversation we need to have. So the people who were in that earlier session, they've seen that we can talk along many different lines, but we can also try to act along many different lines about decolonizing. All of us are in that situation. Nobody is exempt. We're all actors. But there is a huge power equation in the whole exercise. So people who know me a little better, I'm working on health system strengthening most of the time. I was a director of global health in Rotterdam at Erasmus University at some point in my life. And the colleagues of Erasmus the Institute Drift, have inserted this curve about transitions into the conversation. And I want to use it a little bit in the background of how we structure this session as it will unfold. Because we're all, if we think about where we stand, I mean, there's people from all continents in this hall. We're all somewhere in the middle, which the transition thinkers call the chaos point. Some of us work in established institutions that are the top part of this graph. institutions like ministries, or established research outfits, or the WHO, or financing institutions that think they have a lot of power. And they dictate to an enormous extent still the conversation and the practice. But they also feel on the inside, I've worked for most of them actually, they feel on the inside that things are not as stable as they might look from the outside. Give you one example, I worked a bit for WHO during the COVID. A lot of internal uncertainty as well. Institutions are also people. So basically, transition thinkers say, go into these institutions, look what they look like from the inside, and you see there's a lot of destabilization going on. On the other side, there is a lot of new things coming up, and on days like this, the Dutch might forget, you think everything is kind of regressive. No, there's a lot of stuff that's coming up in practice, in circles, in communities, in all kinds of settings, that is experimental, but is starting to accelerate. So, of course, the new things often do not have the institutional body yet of the old things. They don't have the institutional force yet of the old things. But they're coming up, and by smart connecting all over the world, we can actually make them go to a level of institutional strength. So these people also find themselves a little bit in chaos because there's a lot of good stuff, but for instance, there's not the right financing, the governance structures do not work yet for these new things. So everybody is a little bit off track. Now, is that a good thing or a bad thing to be in a moment of chaos? Transition thinkers say it can be good and it can be bad. If you take it to be, this is a moment in time from which you can move to something that is really better, institutionally, practically, relationally, in terms of equity, in terms of how we relate to each other, that is the upper corner, and we can institutionalize and stabilize the new, then this moment might not be so bad, but we have to be very clear in our heads and in our hearts to actually stay on track, not fall back into regressive stuff, not fall back into small endeavors and think, I'm too small, I cannot move to something bigger. And so we're all in that white circle, the chaos. Now, there's another activity that is the lower leg. That is, there's some things we should start to really stop with. We should say, finito basta, we're not going to do this anymore. I always use my body to show that. So this is the finito basta leg. We need to really stop with certain things. Now, all of you are in situations, and you can place yourself on this map in different roles, probably. This is a tool to have a conversation. We'll use this tool a little bit in the background, because the focus of our session is not going to be today on making a long litany of all the things that do not work, but trying to see how can we move from that white circle, the chaos point that we all find ourselves in, a little bit up to the new thing, in terms of imagination, in terms of institutionalization. Now, from that perspective, I'm super happy that we have two very seasoned speakers that are going to help us with presenting two cases from their experience. We'll slip the Mentimeter. We're going to just talk with the boxes afterwards. So, questions that come up, keep them in your mind. After the two speakers speak, we'll do a conversation together. Okay? So the first speaker is Dr. Patrick Kuma Abogi. Do I pronounce this right? And so he came all the way from Ghana to meet you all. He's the DG of the Ghana Health Services. So this is the main body for health services in the country. 8,000 clinics, I heard, that are under your guidance. 20 years of public health experience. Went through a lot of the Ghanaian transformations. Personally had a hand in it. So we could not be more happy to have somebody talk about the first case, which is the case of how do you deal with moving to the new thing when you're, sorry, I put this too fast. How can you actually move to the new thing from the perspective of policy? So I would like to ask the technique to put Dr. Patrick's presentation in now, and I'll give you the floor, sir, with a big applause for Dr. Patrick.
Thank you very much, Godlive, and good afternoon. It's a great pleasure being here. I hope I still have 15 minutes. This is an interesting topic that I've been asked to talk about because, incidentally, I also serve on a steering group for the Future Global Health Initiative, which is trying to work on how we provide local ownership for the health initiatives. Ghana health, or the Ghana health system, is probably not as old as some of the Western countries, but we have, as a Ghana country, we have a population of about 34 million, and it's very urbanized. When I started my practice,
I have to see if the slides work.
no, it will work, yeah. Yeah. So when I started my practice, it was 30% urban, 70% rural. And now we are doing almost 60% urban and 40% rural. So that tells you that it's a very dynamic society. A population of 34 million, life expectancy average between 63 and 64, 64 for females. We have economic size of 70 billion. And one advantage that we also have is that as part of digitization, our mobile network, mobile phone penetration is quite high, 139%, with about 64% of the population having access to internet. So that gives an opportunity to leapfrog some of the challenges we have. So Ghana, there are a couple of things, the topic we are talking about. Because of the global connectivity, I mean, I'll just give an example that I understand it took about 70 years for smallpox to spread throughout the world, but it only took a month for COVID to get around the whole entire world. And so because of the connectivity, international collaboration and strategic partnership is extremely important. But this must be done using local prioritization. There has to be a local prioritization on that. We must have local alignment. The context and the values must be looked at because countries have different systems and they understand their systems better than anybody from anywhere else. And so the countries and these countries need to be empowered to design their own paths to equitable health outcomes based on, as I said, their unique insights on health and the political structure and cultural norms. And so building ownership is very important. And I'll give you an example as how a local initiative without any support has been able to flourish in the country throughout as a country. But Ghana has gone through, I think you can see some, as the colonization aspect of it, you can see that immediately post independence, health service was free between 1957 to 1970. But of course, you will have the healthcare if you can see it. If you only get care is free if you have it. And that's how it is. And so there were challenges. And so the government had to introduce some token fees because they needed mobilization of some resources to be able to expand care. Then we went into structural adjustment program, etc. We said, okay, now it's getting too much, so let people pay cash and carry. And it was a disaster for that decade for us as a country because we had a OPD per capita of about 0.7, which means that fewer people were able to access care. Mortality, everything went up. And then the people decided, let's start with some community health insurance so that we mobilize people, we mobilize resources to be able to pay for care. That was not enough. These were just patchy area, but a significant proportion of the population had no access. And so in 2003, the government, out of this, decided that we would establish a national health insurance that will provide care for all, and started very, very small. I'll tell you that Ghana is not one of the richest countries in Africa, but in terms of health, we've done quite a bit of it. And so if you look at the next slide, in terms of the insurance coverage across beside Rwanda, Ghana has the highest, with about 55% of the population who are fully insured, and the package contains about 95% of all the disease conditions that we need. So if I take you to that slide, you see that 2003, when it came up, population of about 55% coverage, which is about 70, almost 80 million people have coverage. Services are expansive, and the sources of funding is tax-based. About 2.5% of value-added tax is what is used, and the premium accounts for less than 5% of the population of the funding. And so these are a local tax-based initiative that has no support from any partner or donor. So it's by DRGs, that is package services. We made an attempt to do some capitation, but because of the challenge of assuring quality and monitoring quality, we needed to really back out and see how we can learn from that over the next few sessions. So as you can see, where we started from, we had very low coverage way back in 2005. I mean, that's when it started. But you can see that there's been a trajectory where we've really seen significant increase in the coverage over the years. Of course, you can see a dips and up there, but these are all part of the fluctuations of either economy or some civil strife that affects that. But you can see that the overall has been the last 20 years, we've been an increase in coverage across the country. And this has not taken place because some party from somewhere was telling us to do with that. But it is rather the people, the communities, the chiefs, who insisted that we must have health. And as the speaker, there's no government, I've never seen any government manifesto in any party that wants to bring down health insurance. Nobody dare touch it. And so it's something that the community are the most important. It's not civil society organizations that will tell us what to do, but the people, in addition to that, the communities themselves, the political structures are very, very important if you set the right tone. Like I said, this is community population-based social insurance, and so women, pregnant women, get it free. So even if you are not insured, don't have a card, we'll give you a card at the time you appear at the facility so that you can seek care. Children under 18 are covered without having to pay any premium. We only need to get a card. And we've also now introduced some digitization that allows people, that allows you to, as it were, get your registration renewed just on your mobile phone. So you don't have to go and queue anywhere. We had situations where people were queuing across the country. But what has been the outcomes? You can see that as part of the outcomes, we've seen under 5 mortality continue to go down until about 40. And so that is in the last or so years. You can see where we were before the introduction of insurance. Infant mortality has also significantly come down, and so has even the most resistant of them, the newborn mortality, continues to go down. And this, of course, will not only due to the financial access, but has made a significant impact in that. But these are things that is also just because it's locally initiated. If you look at the coverage of vaccination, I'm just trying to bring that to see that also population, some of the preventive and promotive services have also benefited from that. You can see how about 75% of all children by the age of 1 are fully vaccinated as the indicator. And we continue to work. We still have some areas where children are not vaccinated at that age. Not only that, has also given us an opportunity, as it were, to manage infectious or epidemics. Ghana sits in the middle of a lot of countries where it's quite unstable, and so we also, like a melting pot, it's a transit point, and so a lot of conditions come in. The last 5 years, we've had to deal with influenza, of course, the almighty COVID, where we had about almost 20 million cases. But based on the community-based system that we have, where the case fatality rate was 0.8%, which was relatively low compared to the average of 2% globally. We've also had Marburg infections. For the first time, we had a Marburg outbreak, and we were able to contain it at source. We've also had, for the first time, Mpox. We never had Mpox until the outbreak came, but we recorded a significant number of cases, and we actually had a significant number of deaths, about 4. I mean, if you look at the case fatality, that makes it very high. But those are some of the things that the financial access has also helped us to really free and be able to improve our services, especially outbreaks, influenza. Okay. But in all this, I just want to show you this important slide. You can see that the green color is the partner support. So you can see that government support, transfers, infrastructure, per diem accounts for almost 90% of the cost of managing healthcare in Ghana. And that tells you that, and you can see a shrinking, the green bar, you can see a shrinking of that population. And so the state must have the say and must have the context and must also have the say to be able to really run these services. But in all this, we still have challenges. And that's why we needed to make some move, a new vision, a new strategic approach to ensure that we provide care to our people. So what were some of the challenges that we had? We realized that the facilities were working in silos. And we are coming to this side because we can see that we are, as a country, we are developing, we are now having non-communicable disease coming up. The infections are still there. We have nutritional challenges. But the only way we can manage it to be more efficient, make the services more efficient, and use less for more. So that's why we looked at it. The facilities were working in silos, were making it expensive. There was no interaction between them. The facilities were had an unstructured system, rendering poor health services. Ineffective referral because of the trust in the primary level had gone down. People were just traveling, bypassing the local facilities and going to the next level, which is the hospitals, to be able to seek care. So we needed to really look and see how we make the cost cheaper for us and also cheaper for the people. And we also had difficulty in tracking people when they are referred back to their communities because it was really unstructured. These were some of the key challenges that we felt we needed. So we had a district hospital being overburdened and that people having to queue, emergency queuing because we're seeing all manner of things. We did an assessment of deliveries and we realized that 80% of normal deliveries are occurring in hospitals, whereas we have almost 2,000 health centers virtually doing only 20% of that. So that is things that we needed to really look at. So there were other things. Despite all these high coverages because of what we were doing, we realized that we had difficulty in reducing maternal mortality, even though we had very high coverages of antenatal, skilled delivery of about 85%. But if you still have a maternal mortality of about 287, it's still too high. And what is missing is quality. Non-communicable diseases were coming. We are finding it difficult to diagnose them. And people are only seeing them when they have a stroke or when they have gangrene from their legs, etc. So we needed to do something. Of course, child nutrition was a problem. A lot of pregnant women come to antenatal care, about 50% plus HB of less than 8, which means that the adolescent stages are very anemic. These are all things that we needed to do. So looking at, as a country, our own health-seeking behavior, we realized that we needed to pool the resources, especially making the primary level more, making it more attractive, promoting trust by the people. We needed to pool all the resources together. There are people who go to the chemical shop to go and buy paracetamol because the last time I had a headache, I was given something, so I have a headache again, let me go and buy the same. So we realized that these are an important group. We have churches who are also providing prayers as part of healing. How do we work with them in all that community? And so when you see that triangle there, that circle there, everybody's in there, sharing resources, both public, private, and working together. so that we can keep cases there. We want to do telemedicine. We have ambulances that will all be part of that network of practice, what we call the network of practice. So that is more of a redesigning of our primary health care, with a sense that we are going to make cases more access proper at the lower, closest to the people, and ensure that services are rendered. So those are some of the things that we are doing. And we are hoping that with this, the design outcome is that there's public and private service the sites are interconnected through an administrative and clinical management model. The network practice is to also increase access to essential healthcare and population-based services by the year 2030 as part of our effort to achieve UHC. You have a universal access to a responsive, better, and efficiently managed quality clinical, emergency, and public health services, and also to reduce the unnecessary maternal and adolescent deaths that we are having as a country. So, as I round up, I want to thank you all, but I also want to say that there's a lot of mistrust in the way countries manage health and their resources. But I can say Ghana is, as a country, 60 years old. Some of the countries who are dictating and they've run systems for hundreds of years. Unless we are given the opportunity to practice, make mistakes and correct them, those systems will never be mature. And I think that's an important message I want to leave on this podium. Thank you very much. Yeah. Thank you.
Absolutely great, Dr. Patrick. I could already start a whole conversation now, but we said we do 2 speakers first. But I couldn't leave you with, first of all, huge thanks for this presentation, which, as anybody who has done a little bit of health policy in this room can imagine, these are milestones of a hugely complex story with all kinds of elements that we could try to discuss together. Not least, as an old mama, I remember the introduction of the Ghanaian health insurance and how all of Africa and the whole world was actually looking at that and saying, fantastic, fantastic. And initially, it looked like all beautifully accelerating. And then at some point, your government came out and said, well, this is more complex. And what I remember at the time was how, as a person who also knows a little bit about health insurance in Europe, I thought this is absolutely fantastic, like what you said at the end. If we acknowledge that things are complex and are not linear and not so quick, we can probably move faster than if we try to hide it or say there's nothing's going on. So at that time, I remember I was applauding your government for actually speaking out so clearly about lessons learned and reassessing as a learning system. So we'll talk more about that, but that is part of, can we open up to this and get rid of all kinds of instructions that come from the old regimes to present glory stories only. It is very, very complex what you told us. So again, very happy that you're here. Everybody write down questions for Dr. Patrick. We'll come back to him shortly. But first, I would love to introduce Dr. Dungal, who actually comes from Antwerp. And he traveled this morning, got stuck at Breda. We're very happy that he's here because the Dutch train railway system was in disarray. So I got 1,500 phone calls between Breda and Rotterdam, but you made it. And we're very happy that you're going to talk about actually a quite exciting story as well. And I have to maybe see if that's... Your presentation is already inserted here. There was an article in BMJ Global just the other month, October. Look it up, under his name and a whole group of the ITM. ITM is like the kids, there's institutes of global health, old style, 100 years old or more. And basically, the researchers at that institute, under also your inspiration, started a soul-searching exercise on what is this institution and this type of research and these outfits, these colonial institutes, or former colonial institutes. What purpose do they serve in this time and age, and how is our research implicated in it all? So he's going to tell us a fantastic story of what he experienced since that article came out, and he will tell a little bit about it. So, Dr. de Gongo, applause for you.
Thank you, Godlive, and thank you for the organizers to invite me. So I think I'm going to tell a story different rather from Patrick. So it's a story, and because I really want to focus, so for the first time I'm going to read so that I don't get astray and to get over the stress from the train. Okay, so, okay, so yes, here we go. So before I start, in fact, I would like to say a bit of my positionality because this counts for me. I'm a human and social scientist, so I'm an anthropologist, a theologian, and philosopher. So this is important for me that I say where I stand as a person. I come from Uganda, where I was born. I live now in Belgium, where I'm naturalized. And with regard to my philosophical perspective, I'm much more on the side of postmodernity in the tradition of deconstruction with Jacques Derrida and Hannah Arendt and the rest. So that's where I am philosophically. So when I'm talking, you'll know that this is where I stand. So from the onset, I would like to disclose that I feel less energetic as I stand here in front of you to talk about decolonization as a power issue in our current context because of the Middle East issue. I name elephants in the room, so I feel a bit powerless. And because also of the current backlashes, not only in our institutions, but also in the politics, the Dutch elections of yesterday. So these things don't make me very enthusiastic, but anyhow, I think it's important to continue talking about these issues of making more justice, much more equality, less discrimination, less domination of one part of the world over the other, and finally decolonizing our institutions that were in the past colonial and that still to work in the paradigms of coloniality. So, so that's, I want to talk about the background of the article. So this, by the way, the slides is what I sent to Godlive was a draft, but they already uploaded, so I'm sorry, they are very detailed. I had shorter slides. But anyhow, so this is the background of our article, which were on the slides I want to present, but anyhow. So I hope that some of you have read the article. So the presentation is based on an article written and published last year. So the social and political background of the article is the false movement, as you can see on the pictures, the South African Rhodes March fall, the Rhodes March fall in Oxford and other parts of the world, and the Black Lives Matter that was reinvigorated in the year 2020 after the murder of George Floyd. So these events led various voices to call for racial justice, for less discrimination, less domination, and so on. And finally, of course, they called for decolonization. So in Belgium, this was not only in the public spaces, as you can see on the pictures, by peoples mainly from the diaspora groups that were asking the removal of the statues of colonial figures from public spaces, but also in academic institutions. Like at the University of Ghent, there was something that happened there, not very loud, and other places. So we at ITM 2020, there was a group of us, some colleagues that were concerned. So we met in 2020 for an informal discussion to discuss the relevance of a decolonization for our institution. So gradually there was a formation of a commission on decolonization. So this looks a bit maybe out of place, but I think it's important that I talk about how we proceeded to write the article. It's not very clear. So it's important that I situate which were the methods that we used to write this short article. So I'll take you a little bit in the underlying method and theoretical framework, which is not very clear, of course, in the article. So when the commission was established in 2020, the members of the commission divided themselves into groups, working groups. And these groups were respondent on different themes. So the themes that we identified, for example, were the artifacts, the archives, education, research, and others. So the working group that was working on research, and I was on that group, we thought that it was really important, and we are really trying to struggle after having read so many articles. So we are trying to struggle to make a link between the discourse that was going on and the practice, because we are doing things. So then we chose the praxis model, which I have on the slides, as a kind of methodology to link the theory that we had read a lot and the practice and our experience as people working on decolonization. So the praxis model allowed us to take a distance in order to apply a qualitative and reflexive approach to the different activities of our working groups. So why did we choose the praxis model? Well, the motivation was to draw on the practice was because of its very nature. Praxis model is an ongoing spiral, as you can see in the previous slide. So there's practice, reflection, critical inquiry, and theorizing, and the aim is to change practice. And because we found that in the praxis model, the theory is important, and that is what academia is about. You need a theory to begin with. So then, there was nothing appealing than the critical race theory. So maybe the question here that why did we opt for the critical race theory? Well, we chose the critical race theory because of the many similarities that we saw that exist between the struggles or against racism and decolonization. So this one was talking to us. So for the people who don't know very much about the critical race theory, well, this was a kind of theoretical framework that was coined by American legal scholars. All of them are Afro-Americans, like Kimberly Crenshaw and the others. And it's an analytical framework to help understand how institutions, including law, reproduce the racial order, racism, and racial hierarchy, and racialized structures in the social, political, and economic systems. It was also appealing to us because, in fact, the critical race theories combines activism, which we are doing, and the critical reflection. So, people who propose critical race theory, they say that what the institutions do in the struggle against racism is, in fact, to reduce racism to a manageable level, but not to eradicate it. So we people who were working on decolonization, we felt that it was exactly the same that was happening, that as I will show, that the previous initiatives to decolonize ITM were efforts to bring coloniality on a manageable level, but not to eradicate it. So this is the outline of the article, so it has 4 main parts. As you can see, the introduction, a historical snapshot, and then the efforts made, and then the other part is about the contradictions. So the introduction, in fact, we use the analogy of the firefighters, which are the most interesting points, and also we use the metaphor of forgetting, amnesia, which we borrowed from Olivier Rutaziwa. And what we're trying to explain in this part is that, in fact, the efforts of global health institutions to do good, there is a tendency of forgetting that, in fact, what we are trying to eradicate in the so-called global south, we ourselves started these issues. So that is the reference to the so-called amnesia or the forgetting. And we also make a reference to the Ivorian reggae singer, who also talks about the double standards of global health institutions in doing good in the developing countries. So in the introduction, we also argue that we cannot go very far when we are working in a Eurocentric way. Then we have a list of research questions in the same introduction. So I will go to the selected historical snapshot a little bit, and then I will go to the most interesting part. So in this part, the historical snapshot, what we're trying to do is to show how our institution was started in a colonial setting. And in fact, what we try to lay out is that our institution was, like many of these so-called institutes of tropical medicine in the UK, in Amsterdam, and in Antwerp, and the rest, in Berlin, and the rest. Most of them were, in fact, established because of European imperialism. That is the first remark. The second remark is that ITM, our institution, did not fulfill a passive role in fulfilling the fight against tropical disease, but that it took also part in the brutal colonial practices that were taking place in Congo. And that ITM, our institution, adopted strategic measures following the changing perspectives in history, like the independence of Congo. And last but not least, we also argue that the rhetoric of helping developing countries by training doctors and nurses to prepare them to work overseas was also not very philanthropic as it is normally stated. Then we go further to say that the other initiatives that were taken before us, before our commission, we call them the colonial adjacent. And what do we mean here? We mean that although these initiatives, the first initiative was in 1992, it was meant to move from the colonialist to the development discourse. And the second initiative was in the year 2000, which was called the switching of the poles. So these initiatives, we call them decolonial adjacents because they did not go deep. They were just shallow. So there was no questioning of the root causes of coloniality and colonialism, but it was just a kind of labeling. So then the paper proceeds to explain briefly how the commission was established at ITM. So I would like now to proceed to what we call the contradictions that we are grappling with, and I think this is, for me, the most interesting part. So I'll just give examples. In the article, we outline a number of things that for us remain contradictory and which are dilemmas. And if these things are not dealt with, then decolonization is just one of the discourses that we have in academia. So one of these is Eurocentrism. So in the article, we argue that, for example, we give an example of research and education at ITM, whereby in our Eurocentric perspective, we think that, or we consider other ways of knowing, of doing, and of being as being kind of, non-scientific. This is how things at least are considered. Two, in the so-called capacity building framework that we have also, we view knowledge as being, and the skills as being transferred from our institution to the global south. So these all, we label them as contradiction. Then the other one is, of course, the most evident is the continuity between the past and the present, and this is manifested by, for instance, by our arts and our archives. So I don't know how many of you have come to the ITM, but at least in the article we explain this phenomena of the colonial sculptures and paintings, which are so unwelcoming to people who come from the colonized countries, which give sense of unwelcoming to people who come from these countries. Then the paper, of course, then concludes with a question, and this question is very fundamental, and it looks a bit pessimistic, and this is because we applied, of course, the critical race theory that considers that, in fact, such things were meant to be permanent. So the last question we give in the conclusion is that, is decolonization at ITM anyway possible at all? So this, we don't give an answer to this question in the article, but we just give a kind of tip, and the tip is that the first and the beginning point will be to change our mindset. And of course, it would be incomplete if I don't talk about the limitations, but they are clear in the article. First of all, we are just a group of people who come from one department, that's one. And then another important one, that we use a narrative way of writing, that could be another weakness. And then, of course, that we also, I could say, had both inside outside role, which is not so evident in research. Then, of course, I would like to conclude with the reception of our paper. So those are some of the reactions that we came in the previous years immediately. So these are reactions that came from researchers on decolonization. And then we have also the reaction from students in our institutions, And then we have also the from the staff of ITM. So these were some of the reaction. And then last but not least, sorry, I go back. Oh, it doesn't go back. Anyhow, so there are reactions from the researchers, from the colleagues, from the students, and lastly from the management, and you can read them. So they were mixed, as you can imagine. I think it's important. We don't say that it's an academic paper. It was received by human beings with their stakes and their interests. So with that, I will end, and I will welcome your questions. Thank you very much.
Thank you so much, Dr. Dudu. I had seen these slides before, and it was very late when I saw them yesterday evening. And that last slide with the quote of the colleagues, "You're doing so much harm to the good work that we're doing here." It kept me awake for 2 more hours, and it was already 5 in the morning when I got to bed. So it's really... Anyway, thank you so much for both your conversations. I'm now going to ask, there's some rebels in the front row that were in that earlier session I was talking about. So I'll ask you to come up, the ones that still feel inspired. Just come and sit, because we actually wanted to create a circle in this room, but that is not possible. So don't be too shy. Oh my God. No, it's really not exactly. Big applause. I see another institutional rebel coming up here. This is Dr. Oscar. Very happy to have you present as well. Okay. Quickly state your name. There's microphones here. Yes, they're working. Go ahead.
Now? Oh.
Yeah. Quickly state your name.
My name is Lauren Jacobson. I'm American, if you can't tell by my accent. I live in the Netherlands, and I'm an advanced practice nurse focused on sexual and reproductive health and rights. So I'm co-founder of a small company here in the Netherlands called Global Health, and I'm also a medication abortion provider in all 50 states in the US. So that's a bit of my personality.
All right. Thanks a lot. I think I have to... I'll move. Yeah, he's very... I know he wants ladies first. That was his answer. I knew it already. Go ahead.
My name is Lekha Rathod. I'm an Indian physician. I've worked with Dr. Bimbola and Dr. Bhakuni on epistemic injustice in global health. I work for MSF and am involved in DEI activities in the organization. Yeah, that's me.
There's a little echo. You don't understand what
Thank you. And I'm Oscar Franco. I'm from Colombia. I'm a doctor and I work here in UNC Utrecht as professor of public health, and I lead the Department of Global Public Health and Bioethics.
Thanks a lot. Okay, 2 empty chairs. Who dares? 2 empty chairs. Please, 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 please help us. Okay, when somebody feels inspired, you can still, in the conversation, come up. I want to start with where you ended, Dr. Ndungu, because... yeah. Great. Yeah, girls' power. In this conference, there's a lot of girls' power. I'm really happy for that. All right. So quickly state your name. There's one mic there, so you can pick it up here in front of you. Yep. Yep, just quickly.
Someone needs to turn it on.
Yeah.
Should I introduce myself?
Yeah.
Okay, hello everyone. Greetings from Ghana again. My name is Koiwa Koilabi. I'm a maternal and newborn health activist. My background is in medical law and ethics. Thank you.
Okay.
My name is Hanneke Dekker. I'm a medical doctor, but I'm also the chair of the Dutch Society of Tropical Medicine. And I feel responsible for colonial history, and that's why I'm trying to sit here.
Okay, great. All right, by now you know the routine. There's also the boxes. I'm going to pose one question to the gentleman, and then everybody can just mix in, yeah? So, Dr. Patrick first. I already said when I heard you talk this beautiful layout of the reforms in recent years and the long history since independence, actually, how Ghana went to what it is currently serving its people with. I could spend probably 3 weeks with you talking about all the details of such a trajectory, but in the context of decoloniality, where, I mean, honestly, in front of this room, where do you feel it's still painfully present? Like what your colleague was saying, there is a presence of coloniality still in all our work. How do you feel that in your work?
Yeah, thank you very much. In our work, we deal more with partners who usually will come with sets of activities that they think you should have, you should do, that works for you. And that creates a lot of problems and creates a lot of back and forth and creates some significant amount of mistrust. And for us, that significantly affects the work that we do. Because there is evidence is your evidence. But there's somebody sitting in a district who can tell you this one will not work in this district. But you think that you've done some research and to work. I think it's meeting in that. And that mistrust is the issue. Because people really love their people. They love their relatives. They want to ensure that they improve health. And so the need to collaborate is important. The need to ensure that even if there's an additional capacity is important. And like I keep saying, systems develop and grow. Those systems need time. But until you are given the opportunity to practice, even make mistakes, you will never get to anywhere. So I think those are the key challenges in terms of programming where a partner decides that we want to reduce iron deficiency in a particular region. But you know that is not your top priority. You have other priorities. How do we meet to ensure that these priorities are mutual? Of course, everybody has an interest, but I think the interest of the state, the interest of the people, and especially the community should always be taken as paramount in terms of trying to deal with these challenges. And I think this forum creates that open discussion for us to really voice our heart to see how do we really come to the table and make sure that our priorities are given priority, not somebody else's priorities and agenda.
Okay, thank you. Now, I'm a little bit of an old mama, so in some part of my life I was director of a big NGO. And I remember my very first visit to Rwanda. And as courtesy visit, I was invited to come to the Ministry of Interior and to pay respect. And the gentleman that was receiving me looked at me and said, "What do you think you're coming to do here?" And I thought it was the best question I heard during that whole trip. So, are you dealing that upfront with your visitors that come, the agencies you're talking about, or how do you deal with what you just sketched as partners that do all kinds of stuff?
I think, as I started my presentation, we need collaboration because a problem in Ghana is a problem in the sub-region. It may even be a problem for the whole country. So we try to judge or to look at that. So what we do as a system, and it's the departments and I've managed is make sure we always have a plan. So as soon as you come, I give you my plan. Let's see whether what you have in mind fits in there. There is the other aspect of spending 5 years doing a lot of work in 2 districts, pooling all our human resources to do something small that may benefit, that may get results, but then the effects on other services are there. So those are some of the things that we need to deal with. That, look, you can't do this because it's going to pull all my midwives from conducting delivery to working and doing other data collection from you. How do we arrange that? So we have a way of doing that. I think Ghana has developed a system of what we call the Health Summit, where we have a partners group where we meet every quarter and discuss priorities. And so it becomes quite difficult for you now to come and bring something out of the blue because we work with our partners in developing the plans. We work with them in monitoring the plans. And so I think that's the way we've been able to deal with it in a way that this is the plan that we have bought. And we signed an aid memoir that these are the things we say we want to do. So all support must fit within that. I think that seems to be working. But of course, we still have other agencies that work outside that agreement, irrespective of the fact that they are doing signatory to that, we still do that. So it's quite a difficult thing, but we'll continue to engage. But we are not, we work more collaborative. Because sometimes we believe that the person sitting next to you may also be carrying the agenda of somebody else. So how do we get the person to be able to get convinced that he can go back and see how we get? Sometimes it takes about 3 months, just especially in my department, to agree that we move things forward. And I think Koi knows a bit about that. Thank you.
I think Koi is sort of smiling, like you recognize all this. I'm actually asking one of the people on the podium of the recent... could you ask what you wanted to really urgently ask Dr. Ndungu? And then I'm looking at the whole in the meantime. So can you maybe, when you listen to the paper, the second presentation, I thought there was a richness in that. Okay.
It's you.
Oscar, maybe. Go ahead.
Charles, let's bring this conversation a little bit uncomfortable. Let's talk about the transparent elephant in the room. There is racism and xenophobia in the institutions, but institutions and governments and societies are not racist or xenophobic by themselves. They're constituted by individuals, and they are the ones who are actually manifesting this. Some of your colleagues in ITM felt offended because of the comments you were writing in the paper. And I'm struck with one of your sentences about how racism has not been eradicated, but made manageable. How do we move from manageable to eradication? And what is the message that you could share with all of us here and your reflection? Because it is up to us, not just institutions and societies, to actually take an action to eradicate this big elephant.
Thank you very much. That's a $1 million question. Eh? It's very complicated, and from the onset, I say I don't have a black and white answer, but I'll meander a bit. Well, I think just two tips. So to move, for instance, the two examples I gave that we had in the 90s and the beginning of 2000 at ITM, that the colonialism was just brought to the manageable level. I think the biggest problem was that people in management try to do this, but you cannot be like that. You can't do that. I really believe that the work of either the anti-racism or the decolonization and all stuff that are struggle for social and economic justice, they should be given to the people, to the whole organization. There should be a conversation from the grassroots, first of all, not the manager or the director who wakes up and comes with like switching the poles or whatever. So it should come from the grassroots. That is the first thing. The second thing, I think I echo what Patrick said, that I think people who are concerned in these issues of power imbalance, they should be given now as I talk, the capacity to have a lead. You know, the problem that we tend here in Europe, I consider myself European. I live here for 25 years. I have worked here, and I have gone also to the so-called missions in our countries. The problem that we want to tell people what to say and what to do, and this should stop. So we should make people take a lead, tell us what they want to do, present their own programs. We may like them or not, but it's their programs. So that is what I would say as kind of tips. It should start from the people who are concerned, not us here sitting in front of our laptops, developing all these kind of jargons and whatever, and then say that this is the way things should do. Otherwise, you know, these are our own institutions, they are stakes, there are our jobs in question, there's issues of money, there are issues of power. So if you want to eradicate, then we should step aside and be ready to lose some of these privileges and give the power to the people who have been exploiting for years and years. Thank you.
I'm faced with a super frustrating task because the color has just come from green to red on this screen. So we have 6 minutes to
We have two
assemble.
questions here, and here perhaps we spend
They'll get it. I'll assemble the questions, but I also want to see in the hall, because there were some people that were giving signs. So where is the big boxes? Are the people?
It's available.
Is it okay that we just assemble the questions and then come back to you? Is that all right? So there was one box here. Anybody? I can't see too well from here. Okay, now in that case, we come immediately straight to you. So go ahead.
I actually just wanted to thank you for your paper and everything that you just said in response to his question, because it echoes a lot of things that I and my colleague Putri, who I'm going to read something directly that are their words in a moment, have been mulling over. But when I saw the comments come up on the screen from that paper, I had to smile, because to me that's a success. This paper has made people uncomfortable, and that's good, because change doesn't happen if we're all sitting in our comfort zones. So I think when we talk about grassroots mobilization, when we talk about power, and what everyone in this room has power in a different way, whether you know it or not, but when we talk about what we can do as individuals and as a collective from the bottom up, it's push yourself outside of your comfort zone and sit there, because that is where the change happens. So if you're not uncomfortable, you're not doing it right. And that's how I feel about, making change. And then my colleague, Dr. Putri Bidi Saraswati, is an Indonesian medical doctor living here in the Netherlands and couldn't be here today, but it was in the VEMOS session from the other day. And I asked them if there are 3 things that I can convey on your behalf during this conversation, what would they be? So if you don't mind, because it's all relevant to what you're talking about, I'd like to read what they have had to say. So in line with everything we're talking about, Dr. Putri says that we need to recognize that colonial legacies still exist today in global health, as you've mentioned, and development sectors, including the neo-colonial practices and the legacy of imbalanced power dynamics. Solving this imbalance in power is the responsibility of all and cannot be the sole responsibility of countries from the majority world to be so-called assertive. Some stepping down and stepping aside are required, which I believe we just mentioned as well. So in order to make global health truly global, improvements are there, but we still need to critically ask, who is global health for? Who has access to it? Whose voice is heard more than others? Who can exercise power over others to get their interests met, etc.? And finally, the elephant in the room that I think we've mentioned, and I'm sure a lot of us read and hear and feel every day in different capacities, we need to work collectively to free the people of Palestine, Sudan, Myanmar, the Rohingyas, and all oppressed people in the world. Health is a social justice issue and cannot be separated from all other social justice issues, from colonial reparations, or be depoliticized. And so this is an uncomfortable topic, I know, for a lot of us, but it is the reality in which we live. We have to channel the intersectionality.
Thanks very much, and also to the colleague who made you the messenger of this important message. I think we all feel in the conversations we had over the last few days that this is the subplot. We're all uncomfortable. In the slide that I showed you earlier, we're all in this chaos moment. We don't feel well, and that is actually an asset. We should not feel too well as long as all these things are continuing and the power dynamics are as they are. So the uncomfortableness can actually be made into an asset. That is also what your colleague was saying, and I can only applaud him for that. In the final round, because we have a next session in this room that needs to be prepared, I want to do 2 things. While the speakers are thinking about the takeaway, including all of you who are sitting here, last takeaway message, I want to also give a special thanks to the technique, because these guys, they're constantly improvising, new people come in, etc., and they're working in the background. I've now seen backstage. I think they need an applause, and they can... Okay, final rounds, and I start with our speakers of honor. Dr. Patrick, if this is only, we're not even scratching the surface here, but we're all in this space of reflection. So what would you say could be a slightly braver next step that we could take collectively?
I didn't hear properly.
what do you think could be a braver next step that we can take collectively? Because we're all in this conversation about what to do with this colonial remnants and persistence.
Yeah, thank you. I believe that...
Yes, Wyatt. Yeah.
This is better. I believe that the lessons have been clear, that given the opportunity, countries with their local resources and their expertise, with some support, are able to make a leap, also address the problem because of the unique context within which, whether being its research or being its program or service delivery, I think these are areas that we need to recognize. It doesn't mean that if there are obvious challenges, we are not supporting, but at least the first option will be for the people to see what do you want, how do you think this challenge can be addressed. And I think that's extremely a good way that we can start the conversation instead of going with what we think you need.
Thank you so much. Same question to Dr. Ndungu. What you already in your article gave some brave next steps, what we could do. But how can we move beyond where we are now to something that is doing away with some of this, making it manageable rather than eradicating some of this?
Well, I think just simply, I think we should put stakes in the conversation. We should really bring the stakes in the conversation. Here I'm talking about stakes of power, because this is really out of the image when we are discussing. We should say that in Europe, in the West, we are really nervous of losing power. So this should come clearly on table. And when we are negotiating, we say that, okay, this is our position and we are afraid of power. So in order to keep some power, how should we proceed? And then we hear what the other side is going to tell us, okay? That's one thing. The other thing is also the stake of, for example, about jobs and money and the rest. These things for me should really become real. So at ITEAM, for instance, we say, why are people like me not PIs or not professors or what? This is all the aspect of stakes of jobs. They are jobs that people want. So for me, we should openly talk about this stuff and we bring them on the table and we say, okay, this is what it is. And what is now, I think, we should do is to see the way how we are going to balance, to share, to do justice, to be blunt. We are going to do justice by bringing the former colonized in our privileges. So for me, that is what I would say. This is the real practice, or praxis, as I said.
Okay, thanks. Okay. We have my co-moderator has been sitting there smiling constantly.
Yes, yes, because
he's going to say some final words and then we'll round up in this room and take the conversation to our tea break because unfortunately we have to vacate the room in a minute. Go ahead.
I'd love to go on for much longer, and I'm sure it's not the last conversation we have. We just have to be mindful of the time. And I want to give you the microphone just for a moment because you've been asking for 10 minutes to be able to join the conversation. So I gladly give up some of my time then.
Just that we spoke about policy and we spoke about philosophy and theory. But in practice, I think there's those uncomfortable reflections that we saw. It comes from a lot of people who are still engaged in unfair knowledge practices in the so-called global south, the word that I don't like to use a lot. So in practice, what can we do to actually prevent that? We're doing quite a lot so far, but I don't think it's enough. We're still involved in so many unfair knowledge practices that are not very just. And I think this is a good start to actually prevent that. That's it. Now
Thanks. There's hardly a better reflection on this topic, I think, than what you just gave. And I'm not even trying to summarize what has been said. I think we started exercising a common language, the language of music. And Leonie Jansen, who I thank very much for being here at the last invitation. Leonie Jansen said it very, very carefully that yes, in music we have the same language. In words, we still have to find that. And in our collaboration in global health, there's certainly words and means that we have to find in order to proceed. But it starts by recognizing that matters may not be as comfortable as we want them to be. It starts by recognizing that we have to have these conversations because it's about fairness, it's about ownership, it's about power, it's about money, and all these things are very difficult to discuss, let alone to change. But it starts by recognizing, I think that you said it somewhere in passing, it's a change of mind. And this change of mind is not done overnight. It's not something that we can enforce. In fact, it's something we should not enforce. It's something that we should live. So in that sense, I believe in this conference, this particular session has enormous meaning. And I'm sure that we'll come back to this. And I'm sure that we need all of your brain power and passion to get to the stage where we eventually think we have eradicated. And I'm optimistic enough to feel that that stage will be reached. Perhaps not in a lifetime, but it will be reached. So thanks very much. Thanks to the audience for being here in a very large quantity. Thank all of the speakers, Leonie, of course, but particularly the two presentations that helped us shaping our mind. And of course, all of you here, you may not have had all opportunity to ask all questions, but at least your presence is of significance. And with that, also thanking my co-chair, Godelieve, we close this session. Thanks very much.
All right, I'm going to break a convention. Basically, I know leave this room, ding dong. We have to clear the room. With a lot of discomfort, because I think we're only beginning this talk. And this whole conference has been full of it. Let's take it outside these rooms and let's take it to wherever we are, because I think this is so vital now. And if we don't do anything, we basically, we'll lose the plot. So thank you.